Hello, everyone. I'm Daniela Filipescu, WFSA President, wishing you all a happy World Anesthesia Day 2025. This day brings our global community together to celebrate progress and recognize the vital role of anesthesiologists in safe, affordable emergency care. Our 2025 theme, Anesthesiology in Health Emergencies, highlights how essential we are in crisis, often on the front line, providing life-saving treatment. WFSA work on this year's annual theme includes focus statements at WHO meetings, new educational resources such as a new tutorial of the week package for health emergencies, a special update in anesthesia issue, and a series of webinars held over the year and also happening today, a chance to learn, connect, and share. Join the webinars. Share your stories through the dedicated photo booth and In Your Shoes campaign, and help us make the World Anesthesia Day 2025 unforgettable.
Hello friends, I'm Sheila Maitra, Chair of the Intensive and Critical Care Medicine Committee of the WFSA. Welcome to the WFSA Marathon session. We have 4 focus webinars with lectures and interactive panel discussions, highlighting the pivotal role of anesthesiologists in managing health emergencies from disaster response to critical care crisis. The sessions will explore preparedness, rapid decision-making, resuscitation expertise, and leadership of anesthesiologists as part of multidisciplinary teams in various health emergencies, underscoring their indispensable role in saving lives when seconds count. Thank you for joining.
Hello, everyone, and welcome back. Welcome to our first session of the marathon, where we'll be dealing with pediatric and obstetric emergencies. And I'd like to start by introducing myself. I'm Dr. Karima Khalid, and I'll be chairing this session with my colleagues, Mauricio and Hisu. I'm Karima. I'm a lecturer and senior consultant in anesthesia and critical care at Muhimbili University of Health and Allied Sciences and the Muhimbili Orthopedic Institute, and I serve on the WFSA Critical Care Committee, and I lead several national and global initiatives to strengthen care for critically ill patients, mostly using the essential medicine critical care capacity building. Hiso, who is my colleague, good colleague, co-chairing this session with me, is a professor of anesthesia and critical care medicine at Seoul National University Hospital, specializing in pediatric anesthesia and pain management. Her research focuses on clinical pharmacology, POCUS, and the use of artificial intelligence to improve outcomes in pediatric anesthesia. Mauricio is from Colombia. He's an anesthesia and intensive care specialist and an associate professor at Universidad 6 in Medellin, Colombia. He also serves as an ambassador for the World Federation of Societies of Anesthesiologists. So just to take you through our agenda, we've all watched the video by Daniela and Sheila, our president and our chair for the ICCM committee. And we'll next listen to a talk on anesthetizing acutely ill child, key concerns and management updates. And the second talk focus on we cannot stop obstetric patient care during a crisis, pandemic, catastrophes, wars, and etc. Safety and feasibility. These talks will each take 20 minutes, and that will be followed by a panel discussion with we have very good experts in this area from different parts of the world, and I will introduce each one of them to you, and we'll end our day with a video on World Anesthesia Day. Just for housekeeping, our Q&A, if you have any questions, please put them in the Q&A part of the Zoom function, so we can see in our Zoom area, there's a function of Q&A, so please put your questions, any questions that you have into that part. And these translations, this webinar uses Zoom's AI translation feature for live subtitles. So please select your preferred language in the settings. And this webinar is also being recorded, and it will be uploaded on our YouTube channel. And the link will be sent to everyone via email. So first of all, it's an honor for me to introduce our first speaker, who is Professor Ina Shariffuddin. She's a pediatric anesthesiologist from the University of Malaya, Malaysia, and the president-elect of the Asia Society of Pediatric Anesthesiologists. She's passionate about improving the safety and care of children under anesthesia, with research focusing on medical education, pediatric air management, and pediatric outcomes. Our second speaker is Dr. Emilia Guasch, who is an obstetric anesthesiologist at Quirón Hospital University and honorary professor of anesthesia and intensive care medicine at Universidad Autónoma de Madrid in Spain. She's a vice president of the European Board of Anesthesia and a member of ESAIC board, the chair of the WFSA Obstetric Anesthesia Committee, with research focused on labor analgesia, postpartum hemorrhage, and patient safety. Then we have panelists, starting with Amrita from India, who is an associate professor in the Department of Anesthesiology at the Institute of Medical Sciences, Banaras Hindu University, Varanasi, India. Her areas of specialization include pediatric anesthesia, ultrasound-guided regional anesthesia, perioperative focus. She's also an executive member of the Aura India. The other panelist is Dr. Victoria. She is a specialist anesthesiologist at Brisbane and Women's Hospital in Queensland, Australia. She's a professor and head of the University of Queensland Main Academy of Critical Care and supervises medical students, junior doctors, anesthesia trainees, and specialists in clinical research and research higher degrees. The other panelist is Dr. Ayuko, who is an anesthesiologist in chief at Miyagi Children's Hospital in Sendai, Japan. She serves as a board member of the Japanese Society of Pediatric Anesthesia, delegate of the Japanese Society of Anesthesiologists, and ex-co member of the Asian Society of Anesthesia, with interest in pediatric anesthesia, pain management, and palliative care in children. Our last panelist is Anju from India. She's the current editor-in-chief of the Anesthesia of the Week and professor come head of Department of Anesthesiology at AIIMS, Bathinda, Punjab, India. She also served as honorary national president of the Association of Obstetric Anesthesiologists in India. And before we start our webinar, I would also like to welcome you to the World Congress of Anesthesiologists, which is going to be held in Marrakesh, Morocco, from the 15th to the 19th of April. So the early bird deadline is coming soon in January. So please make sure that you register and connect and come to the Congress. We'll have many good speakers, more than 20 tracks, more than 20 sessions, and very educational material will be presented there. So please join and let's have a chance to network together. Thank you very much. Now I'd like to welcome Ina to start her presentation.
So, hello and Assalamualaikum and good day, colleagues. Happy Anesthesia Day, everyone. And I'm Ina. Today, I would like to discuss with you and share my thoughts on this topic, anaesthetizing the acutely ill child. Key concerns and management updates. I bring greetings from Malaysia. This is my team from Paediatric Anesthesia Unit in Ismiarti Medical Center. So before we go further, I'd like to bring your thoughts to think about this case. You have a 2-month-old baby, a 4.5 kilo infant who's tachypneic, this saturating at only 91% on air, tachycardic with a low BP, and prolonged capillary refill time. Laboratory findings show lactate high, and at clinical presentation, you saw tense distended abdomen, bilious NG aspirate, and surgeon suspected that might be a pneumonia. Now, let me bring you to these thoughts. This is a critical decision point. Would you bring this patient to surgery now, or would you stabilize first? So, hold that thoughts. And I hope by the end of the session, you will understand the unique challenges in anaesthetising acutely ill children, recognize early signs of physiological decompensation, apply practical strategies for stabilization and anesthetic management. So why do we focus on anaesthetising an acutely ill child? We know that children are not small adults. They have many variations in anatomy, physiology, and pharmacology, along with quality in some of them. In an ill child, these intrinsic differences are emphasized by systemic effects of illness. They will have impaired respiratory function, altered response, and also metabolic derangements. These will complicate anesthesia delivery and increase susceptibility to morbidity and other adverse events. With the advancements of anesthesia throughout the years, pediatric may seem safe, however, significant. In this review, it was stated that anesthetic-related mortality in pediatric anesthesia is about 1 per 1,000 anesthetic in the developed country, and it increases in high-risk children. Sad to say, it is about 2 to 3 times higher in middle-income country, and though data is not very good at the moment because it's very difficult to get the data. However, it was predicted that there is 100-fold greater mortality in the low-income countries. So, in one of the European countries, Netherlands, our colleague Jurgen de Graaf and team has looked into the hospital mortality at their tertiary pediatric institute, and they confirmed that the mortality due to anesthesia is about 1.1 to 10,000, which more or less the same. And they found that mortality was higher in neonates and infants and children with ASA physical status 3 and 4, and in the cohort that we're going to talk today, emergency patient and last but not least, cardiothoracic surgery. And it's this big prospective multi-center study. I'm sure many of us are very familiar with Apricot study, in which they look into children from birth to 15 years old in 261 hospitals in Europe. The overall mortality rate at 30 days is low, and it's reported that none of the reported deaths were anesthesia related. But they brought up that the severe critical events are related to physical status, which means the worse the physical status, the risk is higher, and especially in emergency. The age, the smaller they are, the risk is higher, and seniority of anesthetists, in which the more senior anesthetists will have less complication. Then the same group look into Nectarine study, which they do the same sort of outcome review and look into neonate and infant. However, they found the incidence of mortality at 30 and 90 days was much higher, which is about 3.2%. So now we have identified the group that we have to be very careful about. So in the same, in this study, in this need to able recognize patient. It's dealing with acute unwell child is complex, and the key skills that you need to have is recognition of a critically unwell or injured child, the ability to initiate immediate treatment, understanding safeguarding issue, and ensuring effective communication with child carers. In the next few slides, and with interest of time, I'm going to concentrate on the recognition of a critically unwell or injured child and initiation of immediate treatment. It is important that recognizing the acute ill child be done promptly and in a timely manner. We need to have an assessment framework so we are able to triage this patient appropriately. So we need to look at the severity of the illness, in which we can determine the physiological instability and the organ system involvement. We need to be able to assess and evaluate the organ function, evaluate the cardiovascular, respiratory, renal, and hepatic function, and then assess their physical reserve, assess the capacity of this patient with anesthetic stress. This triage helps us to decide what we will do next. So in order so that we don't miss anything that will change our management, we need to have a framework. So I would like to use this primary assessment as a framework to recognize the acutely ill child. So first of all, you need to look at the airway. Are there any signs of airway obstruction? Breathing, is the child having difficulty in breathing? Circulation, does the child have signs of circulatory failure? Disability or dehydration, is the child awake? Look at the AVPU scales, which is alert, responding to voice, pain, or is the child unresponsive at all? and also at the exposure, whether there's any signs of trauma to this patient and whether the patient has a normal temperature or not. Last but not least, we don't ever forget the glucose. We need to check whether the patient is hypoglycemic or not, because this might alter consciousness, leads to seizure and security compromise. I would not talk this into detail, but I would recommend you to look into the interagency integrated triage tool that is recommended by WHO. It's basically wrap up everything I've mentioned earlier in detail and when you need to triage them to the red zone or yellow zone. So after you have assessed the patient, you need to have a look at some of their blood results and look for infection and inflammatory markers. Laboratory markers that you like to look for infection would be rise up count, elevated CRP, and if available, procalcitonin. Then you would like to look at other metabolic disturbances like electrolyte imbalances and acid-base abnormalities, which will cause severe adverse event intraoperatively for this patient. In malnourished children, when they are chronically going to acute ill, you need to be able to identify this because it will impact immune response, it will increase anesthetic complication, and they will have poor postoperative recovery. However, you might not be able to do much at this point of time because, to improve nutrition in the children will take time. At least it will give us a plan on what will you do postoperatively for this patient. After evaluating the child, you should be able to risk stratify. So you will risk them to low risk, moderate risk, or high risk and critical risk. So once you know and have certified them, only the low risk should be able to proceed to data. All the rest, you need to resuscitate them first before you bring into data. Next, we'll look into the initiation of immediate treatment. You have to abide by this rule that you have to resuscitate before you anesthetize. And to make this again, that you don't miss anything important, I like to go through the ABCD approach. First of all, you looked at the airway. You must ensure that you have a good airway. And if you're going to intervene, you must be prepared for difficult airway. And then you look at oxygenation, whether this patient needs some oxygenation or would be better with ventilation support. And then the circulation, you will have to assess the patient and then you might need to resuscitate accordingly. Then D, you have to look at disability, correct the glucose, temperature, and electrolyte. And last but not least, you have to prevent heat loss and ensure that patient is warm. Let's take a deep dive to each of them. Airway in emergency setting is not easy. The act of securing the airway in pediatric patient is crucial element of care in the emergency patient. And we as anesthetists play a role in the perioperative setting, and sometimes we are called to assist our colleague in ER or in the pediatric intensive care unit. We know loss of airway control in children, if not resolved quickly, will lead to devastating consequences. So why are their airway difficult? First of all, you know that anatomically they are just different. They have larger tongue, smaller mouth, higher larynx, anterior vocal cord, which lead them to have difficult airway. And then they have higher basal metabolic rate and their closing capacity encroach FRC. This will lead to more atelectasis, poor oxygen reserve, and will lead to rapid desaturation. So we know that they can desaturate fast. So this means that success in the first attempt intubation is crucial. Evidence from recent studies, namely Nectarine, CC, and updates from the Pediatric Difficult Airway Registry, PADI, shows that we need to have high successful rate in first intubation. So we need to avoid multiple attempts, as more attempt increases complication, and we need to avoid repeated attempts with the same device. Hence, they recommend that video laryngoscope with standard blades should be the first choice for intubating the pediatric difficult airway, as well for intubating all neonates and infants with normal airway, as this age group has the highest incidence of difficult intubation. This is a bit, some might think that this is a bit controversial, but recent studies and a recommendation from Pediatric Advanced Life Support from many regions has indicated that in these critically ill children, they recommend that we should use tough ETT, except in neonates where limited evidence is available. We also know that oxygenation, they can desaturate very fast. So oxygenation is very important. And hypoxemia should be hindered by using continuous apneic oxygenation during intubation, as it's been shown that this continuous apneic oxygenation will prolong apneic time, delays oxygen desaturation, and allows more time during intubation. One of the ways that we can do that is by giving passive oxygenation. It doesn't matter really whether you want to give passive oxygenation through Thrive, which is a transnasal humidified rapid insufflation voluntary exchange, or if you don't have them, you still can give low flow oxygen via normal nasal prong in 0.2 liters per kilo per minute. It's been shown that although there is both them increase the apnea time, and the increment between Thrive and the low flow 100% oxygen is not that much. So after you have looked into the airway, the next we need to look at the circulation. So we need to ensure that we are able to identify early signs of hypovolemia or shock, because children compensate well until they suddenly crash. This table summarizes the clinical spectrum from mild to severe dehydration. Key clues include, you have to look at tachycardia, delayed capillary refill time, and reduced urine output, among others. It is crucial that a child who is dehydrated or hypovolemic should be resuscitated prior, unless the nature of the illness and operation preclude this, such as massive bleeding from something that can be stopped surgically. Recently, there are many tools available out there for hemodynamic monitoring. I'm sorry about this busy slide, but from this paper from ESP-NIC, which is the European Society of Paediatric and Neonatal Intensive Care, where they look at the hemodynamic monitoring. This is an expert consensus from 12 experts in Europe, and they consist of pediatric intensive care intensivists, anesthesiologists, and cardiologists. And they look at various tools to assess hemodynamic monitoring. But until now, there's no one tool that is purely validated for children. And as we would have thought so, they have recommended that they emphasize on integration rather than reliance on one single parameter. And they also recommend that echocardiography and invasive atrial BP are core monitoring tools. Most importantly, we need to avoid fluid overload, use targeted iterative resuscitation. After assessing and evaluating the type of fluid, whether this patient needs fluid resuscitation or not, of course, the next question is which fluid. I'm not going to go into detail because this is a lecture on its own. Suffice for me to say that you have to look at the maintenance fluid and the replacement fluid. The maintenance fluid, ideally, we should start with isotonic fluid, and we should only add 1 to 2.5% glucose or any other concentration of glucose when necessary, because patient in critically ill, most of them will have a response of having hyperglycemia. So we have to be cautious in this. For replacement fluid, we can use isotonic crystalloid, and when indicated, we should then change to isotonic colloid. So when do we stop resuscitation with fluid? What is the end point? Well, we need to have a goal-directed, age-appropriate, and we need to ensure that we have achieved adequate tissue perfusion and cellular oxygen delivery with our resuscitation. So for this, we need to put together all the clinical indicators, laboratory physical markers, hemodynamic parameters, and global functional recovery. At the clinical indicators, we need to look that we have restored effective circulation by observing and assessing the patient again. At the laboratory and physical markers, we need to ensure that normal tissue oxygenation and metabolism is back. We look at the lactate base excess. And for hemodynamic parameters, we have to ensure that there is a stable perfusion without fluid overload. We can use echo to look at adequate preload and contractility. And globally, we can look at the restoration of end organ function. Patient will have improved level of consciousness and neurological function and resolution of metabolic acidosis. Other consideration that we need to take in acutely ill patient, which I'm not going to touch in detail, is the special groups such as those in sepsis, whether we should follow surviving sepsis guidelines, or pediatric patient with trauma, especially traumatic brain injury and polytrauma, because they also have appropriate protocol for them. So after we have assessed and we have accordingly, then we reach to the point that we will bring them to OT. So are we ready before we go in? Is that enough? Should we just bring them in without doing anything else? So we need to be very prudent about this, as has been shown in the apricot study, that the availability of senior anesthetists is important because they reduce critical adverse event. So we need to ensure, if you're a junior, that you have senior anesthetist help. And then you need to prepare your team and prepare your patient. You need to have strategy. You need to brief your team what you're going to do to anesthetize this patient. And then you also need to ensure that you have adequate medication, monitoring, and equipment to perform this case. Last but not least, you have to ensure that you have active warming device, as neonates and ill children are very prone to hypothermia. So the strategies at the end is to prevent cardiovascular collapse and pulmonary aspiration. You need to tailor to physiology. There's septic shock. If patient septic shock, you can think of ketamine or thiopentone because it has reflexive cardiac effect. Muscle relaxant, you will have to use immediate, you can use Sux or rocuronium. Cricot pressure, there's not much evidence now to use it, but however, it's useful in patient for the prevention of gastric air insufflation if you plan to do a modified RSI with ventilation. Next, after you have attained the airway, we need to look at the lung protective strategies. The consensus of the European Society of Pediatric Neonatal Intensive Care recommends targeting low fraction inspired concentration and low tidal volume. You need to gently ventilate this lung. Another study by our South Korean colleague shows that they recommend that a tidal volume of 5 ml per kilo combined with a PEEP of 10 centimole water may reduce atelectasis, prevent over-distension, and minimize driving pressure in children with less than 6 years old. Mitigating against hypothermia is utmost important, as patient with hypothermic will have a lot of problems. So we need to keep the warm environment, keep child warm by using external warming devices. I'm going to last few slides. After all that, we then need to ensure that once the operation is done, we need to monitor the patient for reshock, hypothermia, and airway compromise. We need to ensure that patient has good pain control by using multimodal and regional anesthesia, analgesia. And then we need to pass over to our colleague in HDU or PICU appropriately by using a standard format. And then we have to have a mechanism to ensure the early warning to track for deterioration. Now, let's look at our case earlier. You remember the child that I brought to your thoughts earlier. So the golden rule resuscitate before you anesthetize. I hope you would know that from the start, this is a multidisciplinary teamwork. And the challenge is to stabilize while preparing for anesthesia. And the key learning point from what we have discussed is to identify gentle resuscitation, careful induction, and team coordination. With that, I'd like to end with key takeaways. Early recognition saves times and life. We need to stabilize patient before induction of anesthesia. We need to tailor anesthesia to the physiology, and we need to be vigilant post-operatively, as it is as critical as induction. And then last but not least, teamwork and readiness underpins safety. We need to ensure that the care that we deliver is child-centered. So to end, I would like to say every child we safely anesthetize is a silent victory of vigilance, preparation, and compassion. Happy Anesthesia Day. And I would like to invite you to our WCA, where we will have another symposium on pediatric anesthesia, and also to our ASPA, Asian Society Pediatric Anesthesiology meeting next year in India, Vellore, India. Thank you very much.
Thank you very much, Ina. That has really been a very informative session and a very good takeaway. So, as you said, we need the key things there to recognize early, to stabilize our patients, to make sure that we tailor our anesthesia to the child's needs, and to be vigilant and work as a team. So they're really good takeaways, and a lot of questions. People are really keen to learn more, but we'll take the questions later. But now we'd like to invite Emilia to give us her second talk now on obstetric patients. Thank you so much. Welcome, Emilia.
Thank you very much, Karima. Thank you very much to the WBFSA to invite me to give this talk. I will try to accomplish all the objectives, and will try to speak about the disasters medicine and women, the role of anesthesiologists in this very special context that we are suffering nowadays more and more often. I have no conflicts of interest. I'm a woman, I'm an anesthesiologist. Those are my conflicts of interest. The goals during this lecture will be to try to describe and to put in the context the current situation nowadays, the anesthesiologist's role in a crisis, the role of regional anesthesia in low resource setting and in crisis that share a lot of common points, and which are the practical lessons that we have to start learning from this crisis. There has been developed during the last years an increasing interest in disaster medicine. In disaster medicine in general, in disaster medicine, women's health, but the less of the interest, but increasing anyway, is the disaster medicine and pregnant women health. We cannot stop women's care during a crisis. It doesn't matter which kind of crisis we are talking about. And we have had recent examples in our modern world about infections, the COVID pandemic, but it's not the only one. Wars and terrorism in different parts of the world, the migration crisis also affecting the Mediterranean area, South America, and many other areas, and natural disasters that happen unexpectedly from time to time, earthquakes, floods, and endemic crises that may happen in different parts of the world. We have to take a look first to maternal mortality. And in Europe, we have a very good statistics about the EMBRACE statistics, that is a periodical report on maternal mortality and a very deep analysis on maternal mortality. And we have seen that maternal mortality is controlled in this area of the world. But if we take a deeper look on that, we see that the private areas, the private groups, and different races and ethnic origins are related to higher percentages of maternal mortality. So we have to take care of poverty, exclusion, and to work in a better inclusion policies in Europe. In this nice editorial focus mainly in women facing crisis, we have the authors highlight that crisis put health services under strain, and during those crises, it is very often described simultaneous violations of sexual and reproductive health services. And not only this kind of violations, it is also being described domestic violence, rape, abuse, teenage pregnancy, and a lot of non very good facts for women's health. Additional maternal deaths, unsafe abortions, lack of policies for contraception, and everything what it's related to the decrease of maternal and women's care. FIGO, the International Federation of Gynecologists and Obstetrics, has launched a statement about ethical treatment of women, highlighting that health is a human right, and all women and children deserve access to highest possible standards of physical, mental, preventive, reproductive, and sexual health care. It doesn't matter where they live or their background in any sense. The American College of Obstetricians and Gynecologists in the United States have also increased the interest in this topic of crisis and women's care during different kinds of crisis, informing patients about local risks, seasonality if they travel, including evacuation plans, promoting maternal lactation during crisis, which it's an important issue, ensuring continuity of contraception, trying not to have two problems instead of only one, awareness of of early diagnosis of distress and trauma, and including inclusive language according to the American College of Obstetric and Gynecologist Policy 2022. They have also included a special path, a special pack for labor and delivery wherever it may happen, the essentials of a safe labor and delivery pack. The American College also increased and highlighted the situation of hospital disaster preparedness for obstetricians and facilities providing maternal care, encouraging the teamwork, including obstetrics, pediatrics, and anesthesia in the plans. Also, thinking about safe locations for laboring patients. Not only the surgical patients have to be transferred. Many scheduled surgical activity may be stopped, but it cannot be stopped at any way labor and delivery activity, and to have a common language using the OB-TRAIN, the obstetric triage by resource allocation for inpatients, trying to identify properly the pregnant patients with a high risk or who may need acute care, and to be trained to work with less resources in these settings. Anesthesiologists, as we all know, play an important role in crisis, and there is a very important call for action that started 20 years ago in this publication from Anesthesia and Analgesia that highlights the importance that the anesthesiologists have to be familiar with the management of victims of terrorist attacks, because we can manage with chemical substances, highlight in this paper that intraosseum access is important, and our ability to work with multiple casualties and to have plans. When anesthesiologists have been surveyed about the education and training in disaster medicine, they have seen seen that anesthesiologists, very few anesthesiologists, reported that they had received enough education and enough training for disaster medicine and public health preparedness. And by the end, in 2024, there is a new call for action that we have to be prepared for forefront disaster response in mass casualty incidents. And meanwhile, women are waiting for delivery. It cannot be stopped. In this call for action, it has been highlighted that some specialties have been prepared along the recent years, like emergency medicine, for this kind of crisis and disaster medicine response. But surgeons and anesthesiologists have increased their preparedness, but not so much, and not as much as emergency medicine. Despite anesthesiologists' skills may be really, really helpful in these settings, as we may help in airway skills. We are experts managing critically ill patients. We know deeply pharmacology. We know also about leadership and administration. We have a transversal vision of this kind of problems. And there are many areas of the hospital where anesthesiologists may work efficiently, not only at the bedside, also with the communication with blood bank, with chronic pain units, endoscopy suites, administration, pharmacy, etc. And there are many types of disasters where anesthesiologists have knowledge, additional knowledge, and may add value, like hemodynamic instability from any cause, poisonings, mass trauma, natural disasters, nerve agent, and respiratory agents, intoxications. Let's take a look about anesthetic practice in some disasters, like the earthquake that happened in Haiti in 2010. It was performed a very important effort in this hospital, in this particular hospital, where the number of beds increased from 74 to 400, and many surgeries had to be performed. They have described the number and the type of surgeries that they performed, not only in this earthquake, also compared to the earthquake that happened in China, and they described many critical incidents, but nothing is mentioned about labor and cesarean delivery that I'm sure it happened during that period. Regional anesthesia has been described as a very important resource in this environment. Why? Because it has a lot of advantages and may allow us to afford different challenges. It is cheap, simple, and safe. Of course, it has risks, like local anesthetic systemic toxicity, but it has a low incidence, a real low incidence of complications when we have experts managing these techniques. It has the additional recent advantages of managing regional anesthesia with catheters, and POCUS, if available, and ultrasound techniques allow to perform more safely and effectively regional anesthesia techniques. Sometimes it is not easy because of lack of ultrasound machines and sterility concerns, and probably with in the future, with a good education policy at national and international level, fellowships, and with the commitment of anesthesia societies and national authorities, we may increase the training, especially in low middle income countries. It has been, regional anesthesia has been widely used for many years in low resource settings and is useful in many surgeries. It gives the additional benefits of managing chronic pain, vasospasm, and reduced costs and length of stay. Low resource settings and catastrophic scenarios share many similar characteristics, but it's nothing new in the field. More than 50% of cases were managed under regional anesthesia during World War II. The catheters allowed improvements, as we have mentioned before, and it allows also that the anesthesiologist, the physician, performs the block and surveillance for a non-physician by a non-physician anesthesia provider, and it allows the anesthesiologist to attend several cases in crisis scenarios. Regional anesthesia has been used and described its safe and effective use in different places for orthopedic procedures up to 96% of cases, and during the recent COVID pandemic, regional anesthesia allowed our own protection as professionals, not inhaling aerosols and becoming ill. Comparison has been performed between different waves of COVID, focusing especially in pregnant patients. And in this particular paper in India, they have compared first and second wave of COVID-19, and they have found maternal deaths in first and in second wave without any difference, and also maternal perinatal death comparing first to second wave. They have seen also in this paper the high incidence of many comorbidities and and all the situations that may happen in a non-pandemic situation. It means miscarriage, cesarean section, emergency, elective C-sections, abruption, chorioamnionitis, etc. The important is not the difference between the first and the second wave. The important thing is that deliveries and emergency and scheduled C-sections happen during pandemic, during wars, and during any tragedy. Another tragedy that we are living nowadays in our modern world is migration crisis. The migration crisis affects also women because they are vulnerable, and 12% of this very vulnerable vulnerable population, that this migrant population, is pregnant with no proper antenatal care and with different problems, including migration and pregnancy. They have people who attend this population have been prepared to different emergencies, including obstetrics and neonatal. And this is a list of medical equipment and personnel needed on board of the boats, any vehicle that they may use for migration that should be included. But nothing is mentioned in this paper about the role of anesthesia or the possibility of doing anesthesia. And it's important that in this list, emergency delivery is described, fluid resuscitation, oxygen, ambu mask, and many other techniques that anesthesiologists are really skilled to perform very effectively. Going deeper in this migration crisis, there are examples of the migrant crisis in Mexico, and it has been described in this paper that 30% of this population are women that deserve, as many other populations, as any other population, skilled healthcare, prenatal care, contraception, and also labor analgesia and anesthesia for a safe cesarean delivery that it's not described yet in this paper. There is also a very important migration movement from Venezuela nowadays to Colombia. And there is a description in this paper also about lack of prenatal care, about emotional vulnerability that has to be taken into consideration, nutrition, poor maternal and neonatal outcomes, and health system stress because of this important migration. In this paper, it is described that 45% of cesarean delivery, and nothing is mentioned about labor analgesia that these women also deserve as many other women in the world. Other kind of tragedies, the floods that happen more and more often because of the climate change. In Pakistan, the monsoon of 2022 covered 30% of territory and was responsible of up to 1.5K deaths. At that moment, many women were pregnant and 73K were near term. It was described because no access to health services, the use of veterinary medicine, untrained attendants, and for sure, maternal mortality and perinatal damage. Even more than in 2010. So we have not learned a lot from previous tragedies, where it was reported a high number of abruption, obstetric trauma, PPH, or sepsis. So there is an urgent need to put patients in the center in the climate disasters, focusing on women, asking the governments for policy making, communities for managing disasters, professional societies for a higher implication, and physicians for education of the colleagues. We have another example, the earthquake in Turkey. There were 48,000 deaths with important damage to infrastructures. And in terms of women's health, the work described more abortions, premature deliveries, and complications. Oncology women could not receive treatment, and family planning infections and gender violence increased during that period. The challenges are national and international teams, preparedness for disasters, and to have good trained electronic systems for triage of women, and to have protocols for minimal attention in following and next disasters, to reserve safer spaces for women, and enhance coordination with hospitals. But not only the civil population have damages during the wars. It has been described in Ukraine, the effects of reproductive health on female military personnel. We have females and even pregnant females or women who want to become pregnant in the military personnel. And there are other areas of the world who may have endemic crises, and they have published this from my side, very important paper. I hope all the world don't forget women in Afghanistan. They had to interrupt this survey because it couldn't be completed for different reasons. And at the moment, they describe it as systemic discrimination and lack of access to essentials for women with a high maternal mortality ratio. During the wars, depending on the resource level and the available options, the advantages and disadvantages. In the intermediate field hospital in the war, it is much better to perform regional anesthesia because it's highly effective and has lower risk for than compared to general anesthesia, and provides a better pain control. It requires trained staff and sterile techniques. In advanced hospitals, stable hospitals out of the field, for emergency obstetric surgery, we can perform general anesthesia with intubation to practice multimodal analgesia, and it's a different environment than the field. From the WBFSA, and especially from our committee, the obstetric committee, we are really committed with labor analgesia all over the world. And we have launched a declaration in May, the Declaration on Patients' Right to Labor Analgesia, that highlights the importance of laboring women and the access, respectful access to pain relief in labor when women ask for that, independently of their background, religious, ethnic, or economical background they may have. This declaration has been endorsed at the moment by more than 50 national societies, including the first one that was the American Society of Anesthesiologists and the European Society of Anesthesiologists. And let's not forget the Confederation of Latin American Societies of Anesthesia that happened also very recently. From my side, the key points in the practical field is always prioritize regional over general anesthesia, like in low resource settings, use local anesthesia and non-pharmacological measures when resources are minimal or lacking, avoid general anesthesia unless life-threatening emergencies, prepare basic obstetric kits with lidocaine, spinal needles, and the recommended kits for an emergency labor that it's recommended by the American College of Obstetric Anesthesia, of Obstetric and Gynecologists. And the take-home messages from my side is always be ready. As we are anesthesiologists, we know what it means. Think on women's well-being at any moment. They are at least 50% of the population, and pregnant women are the future of our species. It is the moment to act and teamwork. We have raised the awareness, but we have to act now and to lead now. Maybe a fellowship or a professional development module in our national societies may help. Let's learn the lessons from experience, and we are in the right place to do this work. WFSA gives the perfect framework for this. So happy Anesthesia Day, and we wait for you in Morocco, in Marrakesh next year. Thank you very much.
Thank you so much, Dr. Emilia, for that very, very informative, very enlightening. We've learned a lot, and we've seen there's so much work we need to do as anesthesiologists, and that is why WFSA is also keen on this theme of anesthesiologists or in health emergencies, because we have seen a lot of work that needs to be done moving forward, and very good work with the obstetric committee for coming up with the labor analgesia declaration, which is really going to help change the way we treat labor analgesia globally. Now I'll hand over to my colleagues, Mauricio and Hisu, for the Q&A session. Thank you. Hisu,
Karima,
the floor is yours.
yes,
Thank
thank you so much.
Thank you for your
Yes,
introduction. Okay, I go first. Okay, my name is Hisu Kim. Now we will begin the Q&A session with our panelists. Okay, I will pose a question and some of the panelists are welcome to answer it. Okay, let's start the first question. Okay, Dr. Amrita, I have a question. Okay, in recent resource limited or crisis settings, how can anesthesiologists balance the rapid life-saving interventions with longer-term system resilience, particularly in pediatrics and obstetric care? Please, Dr. Anita.
Yeah, I can. So, Dr. He, for that, thank you for that thought-provoking question. And so, working in one of the India's largest tertiary center where we caters a vast and diverse population, I have learned that as anesthesiologist working in a very high demanding environment, we carry a dual responsibility. That is, we need to act fast in the moment, yet we need to think what is ahead in the future. So in our setting, the balance between the immediate intervention and the long-term resilience lies in something a word called as responsive resilience, where the ability to rapidly adapt to the situation, yet converting that experience into a more structured approach for the future. So I will share one experience with you. So it was a very hectic, demanding day where we were simultaneously running multiple ORs. All our ORs were busy with some pediatric and some emergency cases. So we got a call for a preterm baby who presented with intestinal obstruction and was in need of urgent surgery. So postponing that case would have led to the bowel necrosis. So to prevent any delay, what our team decided to use a neonatal ventilator from ICU and then maintain the anesthesia intravenously with precise titration and dosing. And we came out successfully. The baby was stabilized, and actually that experience became a catalyst for our innovation. So now we have developed a dual modality preparedness protocol where we are ensuring a neonatal ventilator at least to be kept ready, cross-checked, and one IV anesthesia plan formulated and kept ready. So in scenario where we don't have anything as a backup, we are using them as a backup. So with same and similar experiences, now we have developed a 3-tier approach. To keep it simple, stabilize, standardize, and strengthening the system. So just to stabilize, initially we are having a pediatric induction kit where we have kept few pre-filled syringes, a well-laminated weight-based drug charts, and color-coded airway kits. So even the newer resident who comes to pediatric anesthesia at least can respond within seconds. And to standardize, we are now conducting a monthly low-cost, high-impactful simulation drills for pediatric resuscitation. So that ensures us a consistent framework. Even the leader is not there, we know what the protocol runs in our institution, which everyone can follow. And finally, to strengthening, recently we have started a low bandwidth telelinkage that is between our institution and the district hospital. So which has become an easy guide for the airway and the resuscitation efforts in real time. So the mantra is resilience is not built after the crisis. It has to start within when the crisis is on. I hope I answered your question.
Okay, thank you for your nice explanation. Simulation and the protocol, making the protocol is a good idea, I think. Yes, it's good. Okay, I have another question to Anju. Are you there, Anju?
Yeah, I'm there. Yeah.
Okay. How can we better integrate the anesthesiologist into national emergency preparedness frameworks, especially where they are still under recognized in leadership roles? Please.
Thank you so much, Dr. Kim, and very happy World Anesthesia Day to all. Actually, a very pertinent question, especially in all resource limited as well as in middle income countries. It's important that we change the narrative for anesthesiologists. I believe we need to move from being perioperative physicians to one who would be not only perioperative, but an entire keeper or, of the patient's physiology. So we need to become a physiologist, a specialist who keeps you alive when your physiology is failing. And I think this is a kind of a mantra that will work in all kind of disasters. And more important than that is the fact that we really need to push ourselves out of our operating rooms to be seen as leaders, because we all know that we have great skills in resuscitation, advanced airway management, keeping our patients hemodynamics and organ support. Having said that, we also are good quality and safety leaders. So I think it is time that we kind of formulate societies within our national societies or committees within our national societies that look at preparedness protocols and also education initiatives under the umbrella of WFSA. And then we push ourselves aggressively into health ministries, into administration, posts, and make them realize the importance of having anesthesiologists up there. And one of the very good ways is to create a database that can create value and show them how we can make the change. So it's important that across all LMICs, we collect data, as Emilia has very rightly pointed out, to various disaster zones, and we can perhaps pick up some of those lessons. We can adapt the safe OB courses that WFSA offers, have local champions, create a kind of a data to show it to our administrators that having anesthesiologists as leaders in these war, disaster, or any kind of preparedness committees at national, international levels would really make a huge difference to the outcome of our patients, especially mothers and children. I think that is one of the way forwards. And I think at local levels, we can have anesthesiologists looking at smaller things like sedation services and protocols and preparedness, getting safe areas where to and of course equipment, logistics and everything all ready and listed out there with regular multidisciplinary drills. And one of the things that I really want to put forward is, of course, when we look at the safe OB model and the safe pediatric anesthesia model, it looks at low cost, training models, and that is something that will take us forward. But we need to keep on reinforcing, create some sustenance in this, and of course look at funding while we push ourselves as leaders. So I believe that is the way forward for us to have faith and confidence in us to be leaders in education, in preparedness into our national bodies, international places. That is all that I have to, I think that these are my thoughts on these.
Thank you. Thank you. Nice opinion. So good leaders are very important. Okay. Okay. Next one goes to Ayuko. Ayuko, are you there? Dr.
Yes,
Ayuko?
I'm here.
Okay.
Yes, I'm here.
I have a question.
Yes.
Okay. When anesthetizing the actually ill children in emergencies, what are the most common pitfalls or misconceptions that even experienced teams might face under pressure? Please.
Well, I think Dr. Ina's wonderful presentation covered most of the pitfalls we may fall into emergency situation. And if I add one thing, or maybe even the best practiced and established group of anesthesiologists may fail in an emergency and complicated situation from time to time. So because we are sticking to one protocol or sometimes guidelines or repeating the same procedure over and over. So I think the best strategy in that kind of situation is ask for help. And not only anesthesiologists, but also surgeons or PICU doctors or even pediatricians. They can see what we miss in the patient. And maybe, well, in a Japanese saying, 2 head is better than 1. So even 3 or 4 head is even better. So I think ask for the help from multidisciplinary team of doctors is quite important. Another thing is the importance of documentation. Having a precise documentation is key to judge afterwards that what we have done was right. And also it's really helped for us to learn the lesson from the experience and prepare ourselves for the future. The future, we may encounter same kind of problem or same kind of patient with problems. That's my answer.
Okay, great. Yes, to ask the help to help the earth is very important, I guess. Yes, I agree with your opinion. Okay, the next one goes to Dr. Victoria. Victoria, are you there?
Hello.
Hi, yes, I have a question to you. Okay, how can we measure safe and feasibility and ethics when obstetric patients required under urgent anesthesia, but resources are severely limited? Yes, please.
Yeah, thank you so much. So I'm coming to everyone today from Australia, on the east coast of Australia. So we're a really big country, but with a really small population that's quite spread out. And so a lot of these conversations really resonate with me because although we are considered a high-income country, we also often have 2 speeds of our health system. So we have rural communities with lower kind of resources and access to care, as well as the metropolitan areas. And of course, as other people have already mentioned today, when you have those long distances, the transfer of patients, particularly obstetric patients, pre-labor, intrapartum and postpartum, that safe transport and logistics, I think is something that is shared by a lot of us on the meeting today. And I'd like to just touch on a point that Amrita made about a disruption and the requirement to be innovative. So sometimes when the system and the staff and the clinicians are under pressure, as Amrita described, we are forced to innovate. And I think probably we've all been faced in recent times with significant supply chain disruptions, so that the equipment we're using yesterday is not the same as what we're using today. The ampules are different. And that, I think, it is difficult, but it also represents an opportunity for us to reflect on our practice. There are lots of guidelines that go into lots of small detail, but I think in times of pressure, both on clinicians and the system, we need to think in overarching principles. So as Emilia stated, so our overarching principles in obstetric anesthesia may be to achieve neuraxial anesthesia rather than GA, but in a whole different places we'll be using different drugs and different equipment to achieve that. And we may not have much choice in that, but by sticking to overarching principles rather than getting stuck in the nitty-gritty, then I think we can maintain the best care we can in challenging situations for our mothers and babies.
Hey, okay, thank you for your great comment. Okay, because since we have running short time, so let's move on to the next topic. Okay, Dr. Vasco, please.
Thank you so much. Yes, hello everyone. I'd like to start with our pediatric anesthesia panel. There are several questions on pre-induction stabilization and the role of fluids and vasopressors. What are your practical recommendations to achieve optimal stabilization before induction? Let's start with Ina, and then Ayuko and Amrita, please. And Amrita. Ina, go ahead.
Thank you, Mauricio, for that question. And thank you for the participant for that question. It's actually a difficult question to just give one blanket answer. It's always fluids in children and resuscitation in children is something that there's no one blanket rule for it. So one important thing, first of all, we need to ensure after we assess, we need to do gentle resuscitation of fluid. That is most important, because you cannot give a lot without reassessing, because once you overload the patient, small patient with a lot of fluids, then it's very hard to take them back, to take their fluids back. So it has to be small, gentle resuscitation. Using appropriate monitoring. As I mentioned just now in my lecture, there's no one single monitoring. It depends also to what is available to you. Ideally, of course, at the high end, if you have echocardiography at the end, it's a bedside resuscitation, then you can look at the IVC at the left ventricle and look at the kissing ventricle, the collapsing IVC. But how sometimes not everywhere you get it. So look at the basic. Look at the capillary fill, heart rate, and urine output when you're resuscitating. Then I think everyone have Artline. So I use that quite a bit, quite a lot actually. With Artline, I can look at the waveform, at the SVV, and I give my fluid accordingly. And when I see the SVV is okay and there's not much response to the blood pressure, then I'll be thinking of the next step, whether I should start inotropes. So I would not wait too long before I start inotropes, especially when we know that this child is coming in with sepsis or some amount of SIRS, because we know the pathophysiology is all back to pathophysiology. At this point, the SIRS and sepsis will actually cause vasodilatation and leaking, and too much fluid will just increase the intracellular damage, So you have to pick both. You have to play around with both. Yeah. So that's my take for fluid resuscitation.
Thank you, Ina. Ayuko?
Well, I think I totally agree to Dr. Ina's opinion. I always try to balance the fluid as well as getting the inotropes, catecholamine near my side. But I think the fluid is the first, and the catecholamine, or for example, dopamine or that kind of things, is the second thing.
Okay, thank you so much. Amrita?
Yeah. So even I do second on what Dr. Ina told. So actually the resuscitation is not a step approach. It is a dynamic thing. So first optimize the volume. As Dr. Ina mentioned, we have few basic, look for the urine output, for the capillary refill time. And best, if you are not sure or if you found the pathology is a complex, then I go for an echo. Go look for the IVC diameters. But again, it said that in units, talking about the IVC diameter and getting a very conclusive answer for your fluid is not that easy. About inotropes, I am in favor of an early consideration of vasopressurization, especially if fluid doesn't work. It's better to start a bit early because the margin of fluid for the pediatric patient is actually very less.
Okay. Thank you so much. Now, moving for our obstetric anesthesia group. There are several questions regarding the role of simulation, telemedicine, short courses for the training and the management of the obstetric emergencies. We'll start with Anju and then Victoria and Emilia about your recommendation for training, simulation, short courses, and telemedicine role. Victoria.
Thank you so much. Yeah. I think there are a lot of courses available by WFSA. We have the OB Safe course, which is a kind of a 3-day course with also course for trainers. And indeed, the purpose is to not only train the providers with low-cost simulation and obstetric emergencies, especially obstetric hemorrhage, preeclampsia, eclampsia, sepsis, but also to have a chain of trainers who can go ahead and keep doing them at their own centers, have some kind of an ongoing on-site training to their providers, especially to non-physician anesthesia providers, because we do not have enough anesthesia providers across all LMICs, including India. As far as simulators are concerned, I believe having low-cost simulators, low fidelity and virtual simulators, having telemedicine to not only to train people, because there would be areas where there would be low internet bandwidth, so we can have perhaps hand-holding of providers during real crisis situations from experts who can guide them through even simple things like video calling on the phone and perhaps looking at the patient and managing it ahead with the providers on the field. So that is perhaps where we can kind of look at it. We can also adapt a lot of programs that are already under play. I talked about the Feasibility project that is underway in Armenia and many countries. And that is where they go and train with the help of NGOs, and they create local trainers and chain of supplies and logistics, get the local administration also to be part of that entire program, to commit to that program and have local champions that carry it forward. And then, of course, always have a gap analysis and audit and look at what is missing and then keep going back and forth and seeing how we can continue to improve. Having said that, in India, we have the Association of Obstetric Anesthesiologists, and we do run Obstetric Emergencies module. This is a 1-day program where we have role plays and small low-cost simulation modules on each aspect of hemorrhage, preeclampsia, sepsis, heart disease, which is coming up in a big way in our country as well. So we keep doing them, and the purpose is to not only to disseminate the knowledge of the systematic approach to it, but also to create preparedness as well as trainers for future propagation of these skills and keep on upskilling their skills. I think I would love to hear Victoria and Emilia on this.
Thank you, Anju. Yeah, Victoria.
Thanks, Anju. I'm really going to, endorse a lot of the things that you have just said. I think it's really important with simulation to decide what do we want to learn out of this, and what an anesthetic team might want to learn might be quite different to what the whole multidisciplinary team wants to learn or to practice. And I totally agree that so much can be achieved with small amounts of low-tech kit. And nothing can be more powerful than using your equipment, practicing with your equipment in your location with your people that you would be working with in a crisis when it occurs. So I think that's very powerful. And just to touch on a couple of other things is that even just a very low cost and low difficulty thing to organize is reading through checklists and flowcharts with your team. And there's so many great resources put out by the WFSA and lots of other organizations to allow us to do that, so that everyone has the same structure to follow when a crisis strikes. Thank you.
Great. Emilia.
Yes, thank you, Mauricio. I totally agree with my two colleagues. And well, the role of simulation and the modern tools nowadays is really, really important. But we have, I'd like to put the attention in the special crisis. We have to be prepared even for the worst scenarios. And that's not to train in abruption, in PPH, in preeclampsia. We have to train in normal deliveries during an important crisis when we don't have resources for any other thing to protect women's health in general, and pregnant women particularly. So we have to learn and to train to do so, because crises are happening, natural crises, natural catastrophes, wars are happening more and more often in our country. And I raise my voice for the advocacy, a role of WBFSA and the important role of anesthesiologists leading this movement to protect pregnant women around the world. We are skilled and trained for that.
Thank you, Emilia. Now we move to Karima for the closing remarks, and we have a video for the end of the session. Karima, thank you so much.
Thank you so much to our speakers, our panelists, my co-chairs, and everyone who has participated, Jyoti, for all your support in this. And what we can see from the talks, from the questions, how much we anesthesiologists need to be at the forefront in making sure that all our patients, or the children, mothers, are taken care of during crisis, during health emergencies, and that we are very powerful in this because we know our patients really well. We know physiology and everything, leadership. We've had so much, and we have had a lot of initiatives that have been happening globally that we can, or under WFSA especially, that we can be part of, we can contribute to, and we can also learn from the simulations, the courses, and also we can push forward in areas where research is needed more in terms of the most essential resources and most essential skills that our healthcare providers do. And it was also spoken that we're not only confined to the operating theaters and ICUs, but we are needed all over facilities. And that is really important for us to realize and work towards. So just before we close, and there is a video for World Anesthesia Day that is going to be played for all of us to see. Back to you, Jyoti, for that.